Hi, I'm Jeff Eaton, and you're not. I'm going to fly through some diabetes stuff here. There's some really good sort of commercial, previously prepared talks that I will also include on the playlist. So let's just fly through some of the stuff that I think is particularly important. Just some basics here. Why do we call it diabetes? Diabetes means too much urine. And so that's why the prefix for both diabetes mellitus and diabetes insipidus is the same. They both create too much urine. Um, Mellitus means sweet, honey sweet. So basically, we're talking about sweet urine, which is what happens is people with diabetes tend to pee out sugar. I don't think I can emphasize enough that type 1 and type 2 are two different conditions. They really are very, very different conditions. Type 1 is an autoimmune process, generally produces little or no insulin. Because of this, sometimes they'll actually go to an anaerobic metabolism, start burning ketones, develop DKA. Lots of times when they present, they're peeing out a lot of sugar, they're very thirsty, and they usually are underweight because they aren't absorbing enough sugar to increase their weight. Type 2 is not that. It's insulin resistance and some decreased production, but not lack of production from the pancreas. The pancreas is almost always still producing some. I'm not really going to talk about it here, but you need to be aware that there is something called type 1.5. Not necessarily universal agreement that it exists, but this is usually a late onset, which almost seems to have characteristics of both. It's more type 1. They often do require some insulin, but they also do have some of the characteristics of type 2. So type 2, again, always with the Arabic numeral, never with the Roman numeral. Um, this is what the Diabetes Association says, and this is what we're going to try to do. So just to remind you that these folks almost never get diabetic ketoacidosis. It is almost always type 1s that get DKA. So let's go over some of the basics. And again, mostly we're talking about type 2 here. Type 1, they're going to use insulin. There's insulins of various speed of onset. I'm going to let you pick some of that up from some of the other commercial talks that I've added to the playlist. But just to review for type 2, we often will use basal insulin. So that's basically creating a base of effect. Some people will start it at 10 units no matter what. So 10 units of a long-acting insulin like insulin glargine or insulin detamere, and basically giving you that foundation that you can lower the blood sugar and then try to improve it with other medicines like the glinides and the other secretagogues and various other types of medications. The biguanides decrease conversion. They do a little bit more than that, and we'll talk about that in a minute. But really, mostly, the big thing is they're decreasing conversion of stored sugar in the liver into active sugar, and therefore decrease the amount of sugar in the bloodstream because of that. There's other things that basically, we call them the secretagogues because they try to increase the secretion of insulin from the pancreas. The sulfonylureas are the long-standing tried and true. They're effective medicines. They're inexpensive. Two big problems with them. One is they can cause a substantial hypoglycemia, again, especially if you're using them with basal insulin. And the other is they often result in a little bit of weight gain. And most diabetics really don't want to gain weight. They want to lose weight. The meglitinides actually are medicines, which we'll talk about in a minute. We don't use them very often, mostly because they're a little more expensive. They will have a place for those people who are sulfur allergic because, again, sulfonylureas are a sulfa-based medicine. So if you have somebody that can't tolerate sulfa, they really shouldn't be on a sulfonylurea. The meglinitides have been expensive in the past. There's ways to kind of get around that now, but we'll talk about them as we go along. So the other new medicines, or relatively new medicines that we're dealing with, are the incretin medicines, also known as the GLP-1 medicines. GLP-1 is a hormone that has really been sort of recently discovered and recently used to control diabetes. It has a number of different effects in the body. It decreases appetite, it decreases conversion in the gut, but it also causes a bit of a secretagogue effect. The good news about it is that if you use it alone, you essentially have no chance of low blood sugar. Also, if you use it with the usual first-line drug, which is metformin, neither one of those have a substantial risk of hypoglycemia. They basically just don't. Now, GLP-1s are always injectable. We have not figured out a way to get GLP-1 into the system without injecting it, except if we block the enzyme that breaks it down, then that increases the amount of circulating GLP-1, and that's the DPP-4s. The DPP-4s are nice, effective medicines, not quite as strong or not quite as effective as the GLP-1s, but as noted, they're available in oral form, and a lot of the insurance companies like them. Now, the glitazones are medicines that we use that decrease insulin resistance. They help the insulin get into the cell. Pioglitazone is the most common one that we use now. A lot of the other ones have been taken off the market because of liver damage and other issues. A lot of us are hesitant to use them just because some of the drugs in this same category have been on the 1-800 bad drug list, and we have this fear that this is going to be the same kind of result. Pioglitazone does have a long history, does seem to be effective, is not terribly expensive. So again, if you've got somebody that cost is a major factor, these are definitely something that you're going to think about using. Now, what blocks the enzymes in your gut? The acarbose or AGI inhibitors will block the enzyme inhibitors. The other medicines that will have an impact, the SGLT2 drugs really don't block the enzymes, but they will block an enzyme in the kidney that is used for reabsorbing sugar. And so basically, instead of the sugar being reabsorbed, it's just peed out. So the net effect is decreased amount of sugar in the body. These medicines, the SGLT2, seem to have some evidence for two other positive benefits. One is decreased cardiovascular risk. Another is some weight loss. And even a third benefit is a mild benefit as far as hypertension. The biggest limitation of these drugs right now is their cost, but I do think that we're going to be seeing them used more. When I review the algorithms for prescribing medications in a minute from the AACE, you'll see that the SGLT2s have really found favor with this group over the past several years. So what's the role of the nurse practitioner in a type 1 diabetic? Now, some of us don't even deal with it. We just send them to an endocrinologist, let them do the major management. Fair warning, the endocrinologist will still expect you to understand everything and be doing the primary care management. They don't take this over in general, but that is one option. Another option is some nurse practitioners really do get into type 1s and really do try to figure out. There's definitely some laboratory workup that you need to do in the initial phase. There's monitoring that you need to do that you don't necessarily need to do in a type 2. But most of the care is going to be pretty similar just because most of the complications are basically the same and you're trying to prevent those complications. You need to decide though, is this something I'm going to get into? If you do, then obviously you'll need to learn a lot more about insulin prescribing. No matter what, you need to understand, what's going on, because if there's a acute problem, the patient is usually going to come see you. They're not usually going to go see their endocrinologist. So if you are going to manage type 1s, you really need to understand the different types of insulin. Rapid acting, onset is pretty rapid, obviously. Peaks, usually about an hour, can vary quite a lot, but we have a lot of these people that will be taking mealtime insulin. If you have somebody who's on sort of a basal insulin, and then you notch them up and you're not getting good control, or they're having problems with some lower blood sugars, then lots of times you have to just get a good basic basal level and then start doing mealtime insulin. And so the rapid acting are the most common. The short acting, not used very much anymore. Sometimes they are cheaper, so that there is a time that we'll sometimes use regular. The peak is usually about 3 hours. So rapid 1, short acting 3. The intermediate acting, lots of times the peak's somewhere about 5 to 8 hours. The NPH insulins are not commonly used. The biggest reason we use them now is that Walmart actually has something called Rely On insulin that you can get a bottle of insulin for, you'd have to check most recently, but last time I saw it was about $30 or so. And you can actually manage your diabetes for much less money. Most other insulins can be $300 or $400 a bottle. And then the long acting, as we talked about, the Lantus or Glargine and the Levemir or Detamir. These basically don't really have peaks. They get on and stay there for 25 hours or so at a time, and they just hang around. So the mixed insulins obviously are going to sort of average the two, depending on what the mix is. So Afrezza is an inhaled insulin. It was approved in June 2014. I think we still need to stay tuned. Here we are 4 years later, and we're rarely seeing it used. It had been approved a number of years ago and then taken back off the market because it was causing some respiratory issues. I haven't seen anybody get too excited about it. Be interested to see if any of you see it used out in the world. So again, to go back and talk about the diagnostic criteria, if you've got an A1C above 6.4, in other words, 6.5, 2 fasting sugars greater than 125, 2-hour postprandial glucose greater than 119 on an oral glucose tolerance test, or if you've got somebody that has the symptoms of hyperglycemia and a blood sugar over 199, all of these meet the diagnostic criteria for diabetes. So again, just to remind you, the beta stills are still producing some insulin, but probably not enough in most situations. Sometimes it's because the person's very overweight and they really can't produce enough to address a 300 or 400 pound person. No matter what, universally, these cells are also resistant to insulin. The average person probably makes about 40 units of insulin, 40 to 50 units of insulin a day. This is why we see people that are on 60, 70, 80, 90, or even 100 units of insulin a day, just because their cells are so resistant to it that they basically need more, because these people have at least some insulin, the type 2s, they will almost never get DKA, even if they're not getting any sort of injectable insulin. Because of that, though, sometimes they will build their sugars up very gradually, and they'll come up with extremely high sugars. We'll talk about that in a minute. So step 1 is basically always metformin. It's a biguanide. They work by preventing the production of glucose in the liver. We talked about that. They also do provide a certain amount of sensitizing of insulin, similar to what the glitazones would do. And they also reduce the sugar absorbed by the intestines. This last one is important just because as the sugar passes through, it's actually going to generate an osmotic effect, and a fair number of people will have diarrhea associated with this diabetes medication. At least a third have looser stools. Some people it's enough to have them stop. You definitely want to talk to somebody who's like a long haul trucker or somebody that's really not going to be able to get out and go to the bathroom very often. You definitely need to talk to them. I have had people decline to go on metformin when we talk about this side effect, just because they just don't feel like it'll fit into their lifestyle. So definitely have this conversation with people. Other than that, there's really very few side effects. They do talk about lactic acidosis. I've never seen a case. I'm not even really exactly sure how we would diagnose it other than with blood gases and, general non-specific signs such as fatigue and decreased level of consciousness and those kinds of things. But not very common, but listed in the information nonetheless. And so just to review types of oral therapies, the hypoglycemics, also known as the secretagogues, that would be your sulfonylureas and your glinides. The glitazones decrease resistance. We can block enzymes with the AGI inhibitors. Acarbose is the most common of those. It's rarely used just because if we're decreasing absorption, you get even more diarrhea and more gas than you would even with the metformin, because they have a more dramatic effect. So there are occasionally people, right now the federal guidelines say that a person to have a DOT certification cannot be on insulin. Because of this, sometimes we do need to put people on these other medications. We now have more choices, but every once in a while you'll still put somebody on an AGI inhibitor. I actually can't remember the last time I saw somebody that was on one, though. The biguanides, again, metformin is kind of what we're left with. There were some earlier versions of this. And then the incretin meds tend to be very effective, tend to be pricey, and unfortunately a lot of the insurances, they're a high copay, prior authorizations, they need to have failed some other medicines, but as I say, they do seem to have a lot of benefits. The SGLT2 medicines, again, I do think we need to stay tuned for this one. Obviously, there's lots of ads on TV talking about the benefits of cardiovascular. Initially, they said they were the only medicine that had cardiovascular benefits, and the Victoza people jumped all over that just because the GLP-1s seem to also have that. And now they're saying they're the only diabetic pill that improves cardiac outcomes. So either way, those two kinds of medicines seem to have benefit. Unfortunately, they're the two most expensive diabetes medicines still. Colsevalam, basically, this is a bile acid sequestrant. It's a powdery, disgusting, some people don't hate the flavor, but most do. We used it for cholesterol for a very long time to decrease the cholesterol absorption. It also does seem to absorb some sugar, and you get almost some GLP type effects. The problem is that a lot of GI side effects, and most people can't tolerate it, and it really has a relatively modest benefit. There was one person that was trying to use it to decrease cholesterol as well. The problem is that it does decrease your cholesterol, but it really doesn't seem to have any improvement in outcomes as far as morbidity or mortality. Bromocriptine, which is a estrogen agonist type medicine that we use, may decrease hepatic sugar production. As I note, sometimes it has some other hormonal side effects, has a very modest benefit on the A1C. I think you're going to almost never see that used for diabetes, but it is on the list. Glinides, we had talked about these already. They're secretagogues. Just mostly this is talking about why we don't use them more. Starlix or nataglinide is about $50 a month, but it's a TID medicine. You have to take it with every medicine. Every meal, and it does not promote, compliance with that kind of a regime. Prandin is a once-a-day medicine, but it's a lot more expensive. Again, mostly we reserve these for people that are sulfur allergic, and even in those people, we've got lots of other non-sulfur-based medicines that we can use. So these are the glycemic control algorithms. This is the 2013. I'm showing you this just to show you the difference between this and the next one, which was the 2016. Basically, monotherapy generally is going to be metformin. So you got somebody, they come in, their A1C is over 6.5, but often less than 7.5, and you're going to go ahead and start one medicine. And generally that's going to be metformin. I really don't like to start a second medicine unless I absolutely have to, just because if you get a side effect, you really don't know what's causing the side effect. You could start a GLP-1. Again, it's going to be expensive, but it is going to work pretty well. It is, going to usually result in some weight loss. The Victoza people are really pushing the Victoza type medicine. For that, there's even a version that is a higher dose than usually Victoza that is approved for weight loss. The DPP-4s, same kind of medicine, same kind of issue. The AGIs, too many side effects. These sulfonylureas are relatively inexpensive, used a lot, but do have the risk of hypoglycemia and the resultant weight gain. And the glitazones or TZDs, again, they've got some bad press, so a lot of people hesitate to use them. The reason I'm putting up the 2013 and the 2016, and the really only difference is that the SGLT2s went from not a preferred or use them with caution to a preferred medicine. So especially if you've got somebody that is really worried about cardiovascular, or they are somebody that are really influenced by the media and media advertising, they may very well ask for that. Now, if you've got somebody that's got a bit higher A1C when they first start out, you're probably going to put them on metformin and something else. What else? Well, anything that's got a check mark there is preferred. Anything that's got a triangle with an exclamation point in is also an option, but is going to be a little bit more of a risky option. So obviously basal insulin, you're going to have a little bit risk of hypoglycemia. The glitazones, a certain amount of risk of liver issues, and then the sulfonylureas, the risks that we've talked about. Again, a lot of people will start them on two medicines. I tend to start them on one, bring them back in a month or so, see what their sugars have been running, see how they're feeling, and then probably start them on another medicine at that time, unless their A1C is above 9, and especially if they're having symptoms. So the guidelines say that dual therapy is really desirable. Again, I have most of my patients that are on 2 and often 3 medicines, but I tend to get them there, I think, a little bit more gradually than some other people do. Triple therapy is also a choice. And then again, if somebody's coming in with an A1C above 9, now note that there's no other limitation. It's not saying if their A1C is 11 or 12 or 13, there's something different you have to do. They're basically saying if you've got somebody that's got an A1C of 11 and they're not having any symptoms, it's completely appropriate to start them on either dual or triple therapy with these other first-line medicines, with metformin and a Trulicity, GLP-1 that's very easy to use and a lot of people really like is Trulicity. The problem is that a lot of insurances will resist you on that one. But at any rate, now if you've got somebody that's having any symptoms, they're peeing a lot, they're having a little bit of driftiness in their thinking, then oftentimes you will want to put them on insulin. Just to continue from the last slide, I accidentally advanced. Basal insulin dosing, some start you with 10 units. Other people will actually start you with 0.2 units per kilogram. There's no exact science to it. It's definitely something that there's some variability. But if you have somebody that has a really high blood sugar, starting them on insulin may be the appropriate thing to do. So let's look at the side effects of anti-diabetic medicines. This is a great slide, I think, from the American Association of Clinical Endocrinologists. And this is, basically what causes hypoglycemia. So there's a lot of things that don't. You can see that the sulfonylureas can cause moderate to severe hypoglycemia. The glinides do as well, but much, much milder. And obviously insulin is the biggest risk. Insulin gives you the best control of your sugars. The problem is that in type 2s, insulin really is not documented to give you as great outcomes as some of the other options. So weight, what causes you to gain weight? The sulfonylureas. Insulin causes you to gain weight, which I think a lot of people don't realize, as well as the glitazones can cause you to gain weight. Metformin will usually give you about a 4-pound weight loss. The GLP-1s will give you a little bit more than that. Primlinitide, which we didn't talk about here today, is another category of medicines that we'll review at some point, but is rarely used because it's so expensive. SGLT2s will give you a weight loss as well. Issues with renal disease, again, a little more hypoglycemia risk with the sulfonylureas. Anything that's going to cause dehydration is going to be potentially an issue. Again, metformin is something that we use in great caution in people who have renal disease, as well as the GLP-1s and the other medicines. So like anything else, watch the kidney function. GI symptoms, again, this can be a real limiter as far as people using something. So metformin will have moderate GI side effects. You'll have some diarrhea, you may have some gas. The GLP-1s can also have some side effects. Same kind of thing. The AGIs, very severe. The colsevelam, they say mild. My experience has usually been it's more than that. The bromocriptine can have some, and then the primlinitide can have some. Heart failure, the biggest offender for the heart failure is the glitazones. You need to use great caution with anybody that has any tendency towards heart failure just because they can worsen it. And again, this is one of the other risks associated with them. Cardiovascular disease, we're seeing a benefit, a little bit of a benefit from metformin. Some benefit as well from the GLP-1s, and also benefit from the SGLT2s. This is the older, this is the 2013. The newer version of this has more information. And then the glinides, is there some issue making things worse? Maybe. And bone, the two big ones here are, again, the glitazones can have some bone loss associated with them. And then there's a question that the SGLT2s will have some bone loss, and they're suggesting that they be used with caution. So this is the final slide here. How much of a decrease in your A1C will you get when you use a particular medication? These are gross estimates. There's huge variations. This is one of the places where real-world evidence seems to contradict this. Evidence-based practice, evidence that's gotten from RCTs, but at any rate, you're going to get as much as 1.5 points with sulfonylureas, 1.5 points with metformin. So if you have somebody comes in at 10, those two things will give you 3 points. That should get you down to 7, which is a reasonable goal according to the Diabetes Association. The AACE, of course, wants you down at 6.5. Insulin will give you 2.5. The AGIs, maybe 0.5 point. The glitazones, maybe 0.8 to 1. The glinides, 1 to 1.5. The GLP-1 analogs, 0.6. My experience has been that it is substantially more than that. So I do think that there are some better versions. This is a 10-year-old slide, so some of these newer medicines you're not going to know. And then the DPP-4s, are going to give you 0.5 to 0.9. I definitely see more from the actual GLP-1 analogs. SGLT2s aren't here. I don't actually have that data right in front of me, but my experience is it can give you as much as a point, point and a half, sometimes even 2. They can be very impressive with their effects. So this was a basic intro to the diabetes medicines. I've got 2 or 3 other good talks in the playlist, so enjoy.